Top Med Talk.
Hello and welcome to Top Med Talk and our special series of podcasts on the coronavirus pandemic, in which we bring you thought-provoking and informative updates from around the world during these challenging and dynamic times. I'm Geoff Lacey and I'm joined by Top Med Talk Editor-in-Chief, Professor Monty Mythen.
Great to be here, Geoff. Well done for securing this amazing interview we're about to have.
Yes, as you alluded, we are delighted to have as our guest today Professor Maurizio Ciccone. Maurizio is head of the Anesthesia and Intensive Care Department at the Humanitas Research Hospital in Milan and is President-elect of the European Society of Intensive Care Medicine. Maurizio, many thanks indeed for joining us today.
Hi, Geoff. Hi, Monty. This is very nice to be with you today. Thanks for hosting me.
Pleasure. Now, Maurizio, we are all sadly very aware of how profound an impact the coronavirus outbreak has had on Italy and in particular your region in the north of the country. But we understand that only as of a few days ago, Italy finally saw the first day in which there was a fall in the number of active COVID cases in the country. So could you relate to us how the situation is now on the front line in Italy and whether those statistics that seem to imply that Italy's over that peak, whether that's been translated to the healthcare services?
Yes, I think the containment maneuvers that were put in place at the beginning of March are working, have been working, and we certainly see less pressure on our emergency departments and on our intensive care units. It's very difficult to find what is the real number of infected cases, I think, in any country. I'm not going to go into the debate of swabs and testing because I'm not a public health expert, but what you can certainly not debate is the number of sick patients that come to the emergency department and they may need intensive care unit. It's something that it's a real number. And that real number has definitely come down. We kind of had a peak on occupancy of intensive care beds in Lombardy, which has been the most affected region, which is where I worked, roughly on the 2nd of April. On the day, we had about 1,500 mechanically ventilated patients inside an ICU bed. By now, while I'm talking, we steadily come down a bit on the occupancy. Patients are still coming, but at a slower pace and with people that either leave the intensive care bed alive. We're very happy about that. Unfortunately, some people died too. We now are at about 900, maybe a little bit less, ICU COVID-19 ventilated patients.
We wanted to pick your brains about what you have learned over the past few months with regards some of the key management strategies for the COVID patients. And I thought maybe we could start with the use of CPAP, which has kind of come in and out of favor and has been much debate. What is the current standing with you in your hospital? Good, bad, or worth a short trial? How are you approaching things?
So thanks for asking that question, because actually I think it's an important topic to describe, especially in our region. I worked in the NHS for 14 years. And just to give an example on how Italy is organized and maybe how this can translate to the NHS, we have intensive care units, but our intensive care beds are predominantly what you would call a level 3 ICU. For level 2 intensive care, so where you provide organ support like CPAP or non-invasive ventilation, something that you would consider more an HDU type of unit, we do that in our intensive care unit sometimes. But very often we would provide that either in respiratory wards or in other wards in the hospital. So just to put numbers on this, Lombardy before this crisis had about 720 ICU beds for a population that is roughly 10 million people. So you're talking about 8 beds every 100,000 population. When we started to see patients coming through, and I remember it was the 20th of February when we had the bed surprise to realize that we had a secondary cluster in the region by finding a patient into a local hospital already in the intensive care, a patient on his 30s that didn't have any risk factors, didn't travel to China before, he was not in contact with an index case before. It was just an atypical pneumonia that was not responding to treatments. And the intensivist, the anesthetist there decided that there's something that does not fit with a young athlete that is not responding to treatment. There is no reason why he shouldn't. So she basically kind of forced the protocol and managed to get a PCR swab. Then the PCR swab was positive for COVID-19. We realized, wow, we have a big problem here. And if we have a problem like this, we may have many patients if we start testing. And indeed, this was happening. The day after, we started to test more. So from one day to the other, the risk criteria for testing for COVID has completely changed. And I remember seeing the day after, I think, 5 cases coming to the intensive care units in the region, then 10, 14, 20. I think we reached a peak of 150, 140, 150 mechanically ventilated patients at some point. But on top of that, we realized that we had to provide not just invasive mechanical ventilation, but also some non-invasive ventilation, some extended monitoring for those patients that may not require that. So our decision was just very pragmatic. We thought we are going to expand new beds to provide level 3 ICUs, but at the same time, we have to work with critical care outreach teams and other doctors, internal medicine doctors. We even had surgeons coming and help. And we probably created an equal amount of level 2 beds in the hospital. So when you hear the number 1,500 COVID-19 ICU patients, actually, I think probably you can double that number, even if we don't have a database as robust as the one we have for the ICU. So basically from 720 ICU beds that we had in the region, we had to go to basically something like probably 3,000 level 2, level 3 ICU beds. We use quite a bit of CPAP. We use quite a bit of high-flow nasal oxygen only recently. Italy has a strong tradition of CPAP use. We kind of like actually to separate CPAP from non-invasive ventilation. When people describe non-invasive ventilation, we don't like it so much. It is a form of non-invasive support, but we're actually just providing positive pressure. We didn't really use much 2 levels of pressures on this patient. It was kind of a criteria to decide to intubate that patient if we reached the stage in which we had to do that.
Maurizio, in the United Kingdom, we had the opportunity to take your lead very much. So there's been a lot of communication between experts around the world, but particularly within Europe, and the sort of broader also NHS network spoke very effectively to each other. Now, our initial guidelines in the UK, as you know, were very much against using high-flow nasal oxygen and CPAP because of the aerosolization story that is still ongoing in some parts of the world. But we rapidly changed that based on your lead, if you see what I mean. And I think it's been very, very successful, is my impression. And the aerosolization issue taken seriously, with personal protection, does not seem to have played out as far as we can tell.
I think it's a very wise comment, Monty. We certainly have seen, we are collecting some data and analyzing some data. The biggest challenge for this was that you had to learn while you were doing, and you had to make some pragmatic decision on what was best not to put patients at risk. But we did exactly what you said, because we realized that at some point, the best thing was always to cohort COVID-19 patients into an area, and it was impossible to build single rooms with negative pressure. It was just not feasible with the pace of the pandemic coming there. We had to convert a lot of our wards. We tried to put with engineers some negative pressures in the wards themselves, but what we decided was we create some areas that are at high risk, but as soon as you put a step into that area, you have to have full protection. So when you go and work inside, you are fully protected. And what we've seen is interesting. Again, these are more personal experiences and experiences from the region, is that we've not seen much infections in the personnel with proper protection in these very high-risk areas. The healthcare workers that got infected seems more people that were probably with a lot of contacts with a lot of patients, of which maybe you didn't know the status of the patient. It makes sense. Statistically, you're increasing your risk just by seeing more people there. But yes, we used quite a bit of these supports, and we cohorted these supports in areas where we could provide this support.
So we've just seen some early data in the UK related to that very point. Now, it's at the moment, it's not completely verified data, but it's in our health services journal and it does seem the same message, that nobody in the front line who's probably wearing PPE, who can see the very sick patient, appears to have been infected and died with COVID-19 yet. Almost everyone seems to be away from that space, which just really continues to highlight how important it is to take the whole environment very seriously.
Completely agree. The two principles for us work to cope with this. One was to increase the surge capacity of the hospital. It's not just ICU. As you know, for any ICU patient, then you have to think about the number of patients that are not in the ICU, the patient that will need their pathway to recovery after, and so on. So you need really to increase the whole capacity of hospitals. But containment is definitely the principle that has to work in the hospital or in the community. So you start in the community, but we've been incredibly strict to separate flows and to contain this in the hospitals. Also because we had the experience of our poor colleagues in the first hospitals where they didn't know that there was a secondary cluster. And when this was discovered, we realized that many of them were infected exactly because they didn't know, they were not aware of this, and it was impossible at this stage to separate the flow. But if you do separate the flow and you have a system to deal with suspected cases and positive cases and negative cases, if you do put that in place, I think you can reduce significantly the risk for other patients and for your healthcare workers.
Did you initially, therefore, just see it as a holding measure to take some of the pressure off the level 3 critical care beds? And now that demand seems to have plateaued a bit, does that change your approach to who you are giving CPAP for? Or are you going for an earlier intubation approach? How has that changed, if at all?
We were under a lot of pressure, so I think the answer to that is we had to increase capacity as much as possible. I can give you the experience of my own hospital. We were starting with a total of 24 beds able to provide some form of respiratory support for the whole hospital. And now my hospital has roughly 750 beds. Maybe you would consider 550 as fully operational beds all the time. So the percentage of ICU beds was, quite small, but I know the experience from the UK, that's a very similar percentage of ICU beds compared to the hospital beds. Our approach has been the one of deciding we do want to give intensive care to whoever needs intensive care. And in a situation like this, you have to compromise on something. Either you compromise on the volume of ICU care that you can provide, or you will have to accept that you compromise a little bit on the quality of the ICU that you provide. We decided to compromise a bit on the quality in the sense that we thought in this moment it's about saving a life. And if it is about saving a life, I will use an anesthetic machine as an ICU ventilator, and I will try to increase that capacity as much as possible. So I don't think we have, at least in my hospital, we're analyzing the data now. I don't think we delayed any intubation by putting people on CPAP. We decided very early to have very robust criteria at the entrance of sick patients to the hospital to decide, would this patient benefit from a trial of CPAP and non-invasive ventilation, of CPAP actually, I would say more. And then we were giving the trial to that patient, not because we didn't want to use an ICU bed, but just because we thought if it's an appropriate thing, maybe it's a good thing to spare an intubation. And some data that we're seeing now seems actually that it is in line with that. By increasing capacity in this way, and maybe we were lucky, but I think we did work also around the clock to increase the capacity continuously, to bring nurses from other departments to work with us, to bring doctors that were able to free capacity to provide all this respiratory support. We've been always able to have enough beds for the respiratory support. And I think we're one of the few hospitals that luckily didn't have to send patients out, but we did put our pool of ICU beds for a network that was very useful to cope with the surge, so that when the capacity was overstretched into one hospital, we can use free beds into another place. And I would definitely say having a network in place is what has allowed us to provide so much life-saving care for so many patients. I think we treated so far in 8 weeks more than 4,200 mechanically ventilated patients in the region so far.
Incredible. Can we talk a bit now about the ventilation itself? So the initial thought, certainly when here in the UK we were preparing for the surge, was that we would have an onslaught of COVID patients to manage in an ARDS type fashion. And then there's the emerging hypothesis of two different type of COVID patients, two different phenotypes. One being with a relatively preserved normal compliance with not much recruitability, the kind of type L, and then the other one being a more classic ARDS type picture, this so-called type H, which would benefit from the ARDS type ventilatory settings. How is your approach now to these patients? Are you very much seeing these two distinct phenotypes? And how has that changed in terms of when you were first started with the surge?
When we have something new in our lives or in our profession as clinicians, and, it makes us very anxious not to classify things. We do like to label things. However, I really believe that at the beginning, one of the major problems of this was that we were not used to see this volume of sick pneumonias coming to our hospital. I've never seen this in my life, not during H1N1 epidemics that we've all seen. This large volume of patients that would need an intubation. This is really the striking thing and the feature of this. To say that there are only two phenotypes on this, I'm not so sure it's a good way either to treat this patient. My view is that every patient will kind of be, different and may be different. I can tell you from experience that at the beginning, it is true that the majority of these patients will present with severe hypoxia. Hypercapnia is a feature that is not initially very present. But then when you intubate this patient, there is so much variability in their compliance, in their response to PEEP, in their ability to get oxygen in to clear carbon dioxide, and it's so dynamic. What we do in my unit, we have decided to work on shifts for the clinicians that are 6-hour shifts, both for doctors and nurses. This was done because also we had to use isolation cohorted units, so you cannot change and unchange continuously. So when you go in, you will drink a liter and a half of water before going in. Then you cannot really go to the toilet or drink. You just work for 6 hours. And we thought that's the maximum time that somebody can work safely there. And on top of that, we thought it's also a way for people not being exposed too long on this. But on top of that, it gave us the opportunity every 6 hours to do an assessment of the ventilation. So every time that somebody comes in, we will do a quick round of all our patients. We will see the dynamics, the respiratory mechanics have changed. And personally, I don't think it's necessarily very useful to classify just two phenotypes. I think, and that's been my approach, to be fair, with respiratory failure even before COVID-19, I always try to give oxygen and to clear carbon dioxide with less energy as possible on the ventilator. Every time the ventilator puts air into a patient, it could either be like a caress or a punch. I don't think you want to punch those lungs if they don't need to. It is true that I think at the beginning, because of the degree of hypoxia, people were using very high level of PEEPs. We've seen that in our database in the region, the very first days, PEEP levels were quite high. We even published that on JAMA. You may have seen the PEEP level was around 14. And so you also have to remember there were a lot of new units that never managed acute respiratory failure. So, people not used to manage this type of patients normally. With the ability to spread the information that Monty was saying before, to talk to each other and to say, maybe we can start with a little bit less. We've noticed the PEEP level coming down now a bit on the stabilization. And remember, this is so many patients coming at once. It's nice to think that you can do fine physiology on every patient, but the truth is that you need to put the majority in a safe position when they come at 3:00 at night, with so many new people working in our intensive care unit. So our approach now is to try to maybe use a PEEP of 10 with an FiO2 of 80%. Just put the things in safety there and then slowly work fine-tuning a little bit on the higher side or on the lower side what you're doing.
Maurizio, watching this unfold, because as you may or may not know, I'd retired for the second time from frontline intensive care and came back to see if I could do anything to help out. And the first thing that struck me in all of the chatter about how to ventilate people was this badging and debate about whether it's ARDS or not. We seem to have forgotten that that's a symbol. That describes a syndrome that means that it happened acutely, and we don't think it's cardiogenic, and there are bilateral infiltrates, and the lungs aren't working very well. Do you think that we've just got a bit carried away with saying it is or it isn't ARDS? Just treat the patient in front of us.
I agree completely. That's what I was trying to say, is that when you have something you do not know, putting a label there and to get a fixed recipe for everyone may make you feel more comfortable, but I think that could be wrong. I think you're right. We got too fixated on this. Is it ARDS or is it not ARDS? I would say a lot of patients have ARDS, but some patients, they don't fit the criteria for ARDS. You may see that some of them, they may have been sick at home with respiratory failure maybe for, 10 days. So it's not so acute anymore either. But I agree completely with you. I think what you have to do is to think, I have a patient with acute respiratory failure. I need to understand if there is a component there that could be related to other organs. And otherwise, I need to try to ventilate this patient again with the concept of give as little energy as possible to bring oxygen in and clear carbon dioxide. I think if you use these principles, you will find that you cannot use the same level of pressure on all the patients. The variability is just too high.
Maurizio, can I ask you about proning? We are using proning a lot here in the UK, and I'm just wondering, again, whether your approach to proning patients has changed during this process. Are you doing it as a rescue maneuver or prophylactically, or what's your approach again with this now that you've had a few months of experience under your belt?
Again, I think you have to try to use what we knew from the past. We don't have enough time to build evidence here, and I think we need to we need to learn by what we're doing and bring some pragmatic evidence to the mix, but we should not forget what we know from the past. Proning in patients in which you diagnose ARDS and they have a low PaO2 FiO2 ratio has been shown to improve outcomes. So we do use it quite a bit. You will find again that in our intensive care units in the region, we probably use it at least in 25% of cases. Maybe you could use it even more. It's not a procedure without risks. You have to imagine, and I know that in the UK it's been the same, you have so many people working in intensive care that has not worked on that before. The ratio between doctors and nurses has been stretched. So again, it's an individual decision every time to decide, am I bringing some possibilities to improvement of this patient, or am I actually increasing the risk based on the situation that I have now? But we are using quite a bit of proning, and if we decide to do it, we will go for 16 hours minimum, and then we will do at least 3-4 cycles before weaning the patient. And the majority of the proning we used was early proning. However, we've noticed some patients sometimes deteriorating and getting like a secondary hit after they got improvement. And in this patient, again, if they fit the criteria for ARDS and a low PaO2 FiO2 ratio, we've used quite a bit of proning.
Incidence of cardiac dysfunction in a COVID patient seems to be reasonably common, probably multiple etiologies to this, but there may be like a direct, almost a myocarditis type process is what I have heard. In your experience, are there special considerations for the cardiac dysfunctions in these COVID patients, and what have you learned on that front?
So that's another interesting question, because if you see the feature of this patient, everyone talks often about the respiratory phenotype, so the respiratory picture that you get, but the picture that you get in terms of hemodynamics is very interesting, because the majority of patients we looked, for instance, in my case series, despite being profoundly hypoxic, very rarely they translate this hypoxia to tissue dysoxia. And for instance, we find that the prevalence of shock, the incidence of shock in these patients, considering as high capillary refill time, high lactate levels, SpO2 that maybe is on the low side, is not as high as I do remember from treating other types of bacterial pneumonias, for instance. So from that point of view, we find that at the beginning, it's actually very uncommon to have to push the cardiovascular system to deliver more oxygen. Somehow this profound hypoxemia due to the lung problem is not translated to the fact that the system is not able to utilize oxygen properly. So that's one first thing to realize. Then when you go and look at the heart, it is true that you see some interesting things, but it's very important to remember, I think, that you have to do something with the heart for which you see some dysfunction only if this dysfunction is bringing a systemic problem. Otherwise, you may run the risk to overtreat some biomarkers that are released, like troponins, or maybe some problems with imaging that you see on our echoes, and we do quite a bit of echoes. So we do find that these patients, often the heart on echocardiography seem to work with some degrees of right ventricular failure. When we do look at troponins, it is true that troponins can be quite high in a large number of patients. But again, is this related to a direct viral insult to the myocardium, or is it part of this syndrome that we're seeing with COVID-19? I don't think we know all of that yet. But personally, I'm not treating too much this problem. I'm recognizing this problem, and I'm going back to the basics. So I'm actually focused on cardiovascular dysfunction. If I see that this cardiovascular dysfunction is bringing some problems also in terms of shock, in terms of oxygen transport and the utilizations at a more peripheral level.
So, as with your respiratory approach, it's treat the patient. Don't overcomplicate things in some respect.
We are studying a lot, and I'm lucky to work in a university hospital here with great researchers. So we got together very early, and we are studying a lot what's happening. But one thing is finding an association and some observations in what you're seeing. One other thing is jumping to treat that, and I think that could be actually dangerous.
So, one thing you alluded to there, Maurizio, was the fact that some people have been surprised that you don't see a very, very big lactate rise. And that's where we have to remind people, we're a little bit obsessed with the idea that physiology is the polar star. You have to remember how a virus kills, and a virus gets into the cell, and when it decides to break out of the cell, it's a clean shot, it's a clean death. Mm-hmm. So you don't get what we see in the situation whereby the cell is suffering. And when the cell is suffering, that's when it generates lactate. So that until you get the secondary infections or the consequences of the cytokine storm, you're not going to get that lactate signal.
Yeah. I think it's a very valuable explanation. I don't know if it is the only one, but I think it's a very valid explanation. And again, we need to go back and look the patient that is in front of us. We have many tools to understand that physiology, which does not mean that we don't apply the good learning from trials and from strength in the past, but certainly I would encourage everyone to look at respiratory mechanics and the cardiovascular system on that patient on that moment every time you do a clinical examination.
We're starting to see an increasing number of tracheostomies in our COVID patients now. Are you able just to paint us a picture about that aspect now that often you're a bit further down the line with managing these patients? Have you any particular advice or approach to tracheostomizing the COVID patient?
Maybe I sound a bit boring, but I tend to stick to what I was doing before.
I think that's very helpful, though, to hear that, because sometimes we're maybe thinking that this is something that we should approach it differently, but it's interesting to hear that.
I really think, it's back to this large volume of patient as being unprecedented into our units, especially for something that is different from us. Often we treat syndromes, and syndromes come from the very different pathogens. This time we have one pathogen that actually can give a variability of symptoms and signs. But back to how people recover from the mechanical ventilation, I still try to stick to the same principle. So I personally don't do early trachees, if that's a question. A lot of these patients, they may require also pruning in the beginning and maybe for a few days. And so, it's still a surgical procedure, not without risks. So I think, it is something that we do. I have a few trachees in my unit. But again, I have not changed significantly my practice with these patients. One thing is true that we've noticed, but again, we were discussing this also with some colleagues in the UK, and not everyone has the same answer. But anecdotally, I can tell you, we've noticed on the late phase of respiratory failure, when patients recover, despite the PaO2 FiO2 ratio gets better, some of them, they tend to go into an hypersecretory phase of the disease. And we find that some of them, they may not be able to go for an extubation safely just because they may not be able to clear all these secretions. And again, because we're managing so many patients, you don't have all the physios that you had before and so on. Sometimes if we think that the situation could be risky, we may use that to stop the sedation and to allow a better, a more, slow weaning of the ventilation. But again, it's something that we do on an individual basis. It's not that because we have COVID-19, we have a new recipe for when to trachea patients.
And Maurizio, I know you've got to rush off to another meeting soon, but maybe one final question. Can I ask, for those people, institutions that are still awaiting the peak of their surge. Do you have any advice about things you maybe wish you had done or had more time to prepare for, to allow those people to prepare better for the oncoming admissions?
The only advice I would give is, if I go back in time, I wish I'd listened more to the stories and to the data that I was seeing from Wuhan. I remember monitoring the situation. I do remember pretty much everyone when we were going to meetings in January and February. Everyone, you may remember, was present in the beautiful Johns Hopkins map where the cases were. Speaking with many colleagues, I speak for myself, but I know that this is true for many. I don't know how many of us thought that thing that we were seeing from China could have impacted us so quickly, so fast in our healthcare system. So I would say we have enough evidence that can impact anyone, even in a healthcare system of Western countries with good economies and good systems. So get ready is the advice, and the advice is you need to get ready not just as an ICU, but as an healthcare system. And this means that you have to think about your surge capacity, and again, work with containment in the community. This is not something that you can hope to win just by increasing capacity in your hospitals. The R0 of the virus can be so high if you don't take controlling maneuvers in the community, that the number of patients you will see can overwhelm any healthcare system. So, these two principles: increase capacity and work on containment in the hospital, but also in the community.
Maurizio, you alluded to it. One of the first things I picked up from your colleagues that I interviewed in Bergamo with Desiree, it was over a month ago now, was they said that much of the contagion took place within the hospital between the healthcare workers. I just feel very, very sad that we seem to have been very slow to learn that. What have you done about that locally now?
So maybe we were lucky because Bergamo is being, probably the epicenter together with the south part of Lombardy. There has been two big clusters in Lombardy. One was you may hear the name of Codogno. Codogno was a name that no one knew before this, but now everyone knows. And this was in the south of the region. Then the Bergamo area has been profoundly affected. I don't know if maybe we were a bit more lucky in other parts of Lombardy or in my hospital. What I can tell you is, and that's what we also give this advice, also through a letter with the European Society of Intensive Care Medicine: don't work in silos. You need to work with every part of your hospital, from the management to everyone, really, because to create a pathway to separate patients, suspected cases in the hospital is paramount to protect other patients and to protect the healthcare workers. If you come to my hospital now, it feels like one single building, but two hospitals inside. The pathways are completely separated.
But do you wear masks everywhere now, for example, or only in the COVID section?
No, in Italy now, you even have to wear a mask to go outside. And in the hospital, even before that, we do wear a mask. Actually, I think wearing a mask without overdoing it, because you don't need to wear an FFP2 or an FFP3. I think that would be silly, and it removes it from the people that need it the most when it's there. But wearing a mask, I think there is enough evidence out there also from some papers that come out that can minimize the spread between individuals in the community. So we are doing that in the hospital already, and now we are doing it also in the community.
And for those of us with an anaesthetic background, it's not long ago, and it still is the same in some places, that wearing a surgical mask in the operating room all day long, they're comfortable enough. You stop noticing them after a while. And say you're wearing them for the other person. You're not wearing them for you.
Absolutely. Yeah.
Maurizio, I have just one question for you, jumping in here at the end. I know you're busy, but obviously there's been a major strain on staff and healthcare workers there. And, these 6-hour shifts that people are doing with no breaks at all. And now that the surge is kind of passed, just how are you guys coping with this event? Because I know here in the U.S., we're really starting already to see this major strain on many of our healthcare workers, and really concerned about how we go forward after this crisis is over.
Well, first of all, again, you need to work with your own hospital management, I think, as a head of department, as people that manage other people, to basically to tell them how important is the protection I think I've been lucky. I was even able to have a shift in place to allow proper doffing at the end of the shift, because you are tired. To do the doffing alone can be dangerous. It's the most dangerous moment there. I was lucky to convince my hospital to say, I'd rather lose, one shift somewhere else, but I think we need to have somebody always helping people that are tired to recover from this. We also decided, again, something has to compromise. You cannot have everything. You cannot expect to have just ICU nurses for 4 times the number of patients that are coming through. So we accepted and we were very happy to get nurses from other departments. We thought better to keep the ratio between a nurse and the patients to be on the right standard, with one ICU nurse which will supervise other nurses. And this is allowed. Of course, it's a different way of working. The expertise was not the same, but at least the work is shared, and everyone was sharing work there, which I think has been tiring. It is tiring, but I think we've been able to cope. Also because maybe there is another bad news to this. When the society restarts and when the hospital restarts, it's not that we're going to work less. We are going to have a phase in which we have to keep the COVID-19 areas ready for secondary peaks. We hope there will be no secondary peaks, but we need to be ready. We need to carry on working to bring the hospitals back to where they were. Hospitals were there for a reason. All those patients that had their operation cancelled, that all the treatments cancelled, we need to give them back to them, and at the same time be ready for COVID-19 possibly being endemic for a few months or maybe a year. We don't know that. I hope it's not going to be. But it's going to be tough in terms of shifts. And so this is a marathon. This is not a 100-meter sprint. So we need to pace our forces in our hospital to think that it's going to be a tiring period for quite a few months.
Thanks.
Maurizio, I think we're going to have to leave it there, but thank you so much for your time and for relaying such valuable experience and lessons that you've learned over these past few tough months. So many thanks for joining us again.
No, thank you. And thank you for sharing all this information. I think it's great what you guys are doing. I think of all the bad things of COVID-19, seeing how much free information is being around there between clinicians on the internet with your initiatives and others, I think this is very important. So thank you.
Top Med Talk.
And for listeners, please catch more of our COVID-19 special series of podcasts on the Top Med Talk website. But for now, thanks for listening.
Top Med Talk is proud to thank its sponsors, specifically Edwards Life Sciences, for their generous support through this global crisis.